Usually you would think that something that is ultra-sensitive would be even better than what we have, but not necessarily. There are at least some nervous people who are trying to avoid what my guest calls troponinitis. There is a paper coming in the April 15th issue of JACC, and it's Avoiding the Imminent Plague of Troponinitis. We're looking at the need for reference limits for high-sensitivity cardiac troponins. Dr. Christopher Kramer is a professor of radiology and cardiology at the University of Virginia Health System, Charlottesville. This is a commentary, an invited commentary on a paper by Gore et al. Can you talk about their paper first and what they were talking about?
Yes, the paper from Gore and colleagues reviewed data from three of the largest cardiovascular studies, ARIC, CHS, and the Dallas Heart Study. And what they looked at was reference limits that came out of those large patient populations for normal values for troponin T. The published reference value for troponin T is around 14 picograms per milliliter, and that's based on standard deviations above a normal value. The problem with that is that those normal reference values are developed in young, healthy populations. So if you look at older patients with cardiovascular disease, different ethnic populations, that normal range, that low normal reference value must be pushed up. So if you use that cutoff of 14 picograms per milliliter, every male over age 65 would be diagnosed with a myocardial infarction. So clearly we have room for improvement. So what they showed that in certain populations, a normal value is up to 36 picograms per milliliter, depending on the population that you're looking for. This really points out the need for age, gender, and ethnicity normal levels for these values, or else we're going to be in a problem with troponinitis.
Well, if these assays become approved by the FDA before we get all this taken care of, it's going to be a mess.
Yeah, I think it points out really the need that clinicians are going to have to look back at these larger patient populations to really understand where the cutoff for normal versus abnormal, or else we're going to have a plague of false positive myocardial infarctions, especially in hospitalized patients.
So any other advice that you give in this particular piece as to what's needed now?
Yeah, I think what's needed now is a prospective study of a large database which has a wide range of age, gender, ethnicity, so that we understand going forward what true normal values, normal reference limits should be, so that we will have a basis for understanding a particular value in a particular patient and really know, do they have a myocardial infarction or is it just a false positive?
So there's some real trepidation, and there's real reason for the trepidation.
Yes, I think so. As for this, the clinical cardiologist doing hospital-based consultation, half of the consults are for an elevated troponin, and if the incidence of elevated troponin goes up because we have highly sensitive values without reference limits, I think it can be overwhelming.
Well, the paper itself is Gore et al., and that's in the April 15th issue of JACC, and the invited commentary by Dr. Kramer. For CardioSource World News, I'm Executive Editor Rick McGuire.